The causes and symptoms of orthostatic hypertension, its connection to falls, and the importance of assessment through blood pressure monitoring are explained in this Nursing Times peer-reviewed article, which is read to you using an automated voice. The authors are Julie Windsor, Patient Safety Clinical Lead, Medical Specialties Older People, NHS England. Mike Lowry is former lead for clinical skills and simulation. Sarah Ashelford is former lecturer in biosciences, both at School of Nursing and Healthcare, University of Bradford. Dr. Julie Whitney is consultant practitioner in gerontology, King's College Hospital, and lecturer in physiotherapy, King's College London. Dr. Sarah Howie is consultant geriatrician at St George's Hospital. For full citation and references, visit nursingtimes.net, where the article can be found under the topic of assessment skills, or search for Nursing Times, the effect of orthostatic hypertension on falls risk. Abstract. Orthostatic hypertension occurs frequently in older people, particularly when they are in hospital or unwell. It can cause lightheadedness, unsteadiness, and falls. Nurses and care support staff should understand the physiology of orthostatic hypertension and how to assess, monitor, and treat it in relation to falls assessment and management. This second article in a two-part series on orthostatic hypertension focuses on how it contributes to falls and how staff can identify and manage it. Introduction. Falls are the most reported type of patient safety incident in acute and community hospitals, and the third most reported type of incident in mental health hospitals. Data submitted to the National Reporting and Learning System shows that around 250,000 falls were reported in 2015-16 across these three hospital settings. In 2022, the National Audit of Inpatient Falls reported 2,033 inpatient femoral fractures in England and Wales. Falls have both a human and financial cost. For individual patients, the consequences range from distress and loss of confidence to injuries that can cause pain and suffering, loss of independence, and occasionally death. Additionally, relatives and staff can often feel anxiety and guilt after a fall. The costs for healthcare providers can include additional treatment, increased lengths of stay, increased care costs on discharge, complaints, and, in some cases, litigation. The estimated total yearly combined cost to hospitals of reported inpatient falls is around $630 million. In terms of non-hospital falls, the total cost to the UK of fragility fractures has been estimated at £4.4 billion, which includes £1.1 billion for social care and £2 billion for hip fractures. Falls prevention is challenging. A careful balance must be struck between promoting safety and encouraging safe mobility to prevent complications of deconditioning, while supporting patient autonomy to make decisions about care, including risk-taking and considerations of privacy and dignity. Although high-quality guidance is available, evidence suggests that many organizations struggle to put evidence-based falls prevention activities into practice. Recent national audits have demonstrated that, although many organizations have falls prevention policies in place, improvements are needed in the association between what those policies include and the assessments, and importantly, interventions that patients actually receive. Identifying patients at risk of falls. Factors associated with aging that can increase falls risk include loss of muscle strength and balance, orthostatic hypertension, and visual and functional impairments. Older people may also have physical and mental health conditions that increase their risk of falls. Patients in hospital are at increased risk of falling, with pre-existing health problems compounded by acute illness, treatments, procedures, and an unfamiliar environment. Additionally, the prevalence of delirium in patients aged greater than 65 years in acute general hospitals was found to be as high as 1 in 3, making the falls prevention management of patients with impaired cognition and restlessness a challenge in all inpatient settings. The National Institute for Health and Care Excellence, NICE, has published guidance on falls risk factors, the effectiveness for interventions and prevention in hospitals. A key recommendation is that hospitals stop using falls risk prediction tools, which aim to calculate patients' risk of falling, at risk, not at risk, or low, medium, high risk, due to their ineffectiveness in accurately discriminating between those with the potential to fall and those who will not fall. Instead, NICE and more recently, the World Falls Guideline by Montero Odasso et al. Advise that all patients and care home residents aged 65 years and over, and those aged 50-64 years who are considered to be clinically at risk, are offered a comprehensive multifactorial falls assessment to prompt staff to identify and act on reversible fall risks and formulate personalized intervention plans. The falls assessment should promptly address identified individual risk factors for falling that can be treated, improved, or managed. These include sensory impairment, especially vision and hearing, cognitive impairment, especially delirium and dementia, falls history, causes, consequences, and fear of falling, gait disturbances, postural instability, mobility and/or balance problems, continence problems, footwear or foot ill health, health problems that affect falls risk, such as stroke and Parkinson's disease, polypharmacy, plus falls risk-inducing medications that increase the risk of falls, such as antihypertensives, diuretics, antidepressants, antipsychotics. Orthostatic hypotension. The procedure to follow when taking a lying and standing blood pressure measurement is: explain the procedure to the patient. Ask the patient to lie as flat as possible for at least 5 minutes before measurement. Measure BP and pulse rate while the patient is lying down. Ask the patient to stand up, helping as necessary or using their normal mobility aid as required. Ensure the patient remains close enough to the bedside to sit down safely and quickly should severe symptoms occur or they are unable to continue. Measure BP and pulse rate immediately upon standing, or within 1 minute, then again at 3 minutes after standing. If the BP is still dropping or symptoms persist and patient can continue, repeat the BP reading. Notice and document symptoms of dizziness, lightheadedness, vagueness, pallor, visual disturbance, increased postural sway, feelings of weakness, especially in legs, palpitations, shoulder or neck ache. Safely assist the patient to sit down once procedure is complete. Inform the medical team if there is a positive result. A positive result is a drop in systolic BP of 20 millimeters of mercury or more, with or without symptoms, a drop to less than 90 millimeters of mercury systolic BP on standing, even if the drop is less than 20 millimeters of mercury, with or without symptoms, a drop in diastolic BP of 10 millimeters of mercury with symptoms, although clinically much less significant than a drop in systolic BP. Advise the patient of the results and, if orthostatic hypertension is suspected, of the immediate actions to prevent falls and/or unsteadiness. When carrying out the procedure, use a manual sphygmomanometer if possible. Automated sphygmomanometers may show repeated error messages. This may be due to the computerized algorithm that cannot overcome the dynamic readings associated with falling BP and/or irregular heart rate. Orthostatic hypertension. Orthostatic hypertension is an abnormal decrease in systolic blood pressure, BP, within 3 minutes of standing, and has been defined as a systolic drop of more than 20 millimeters of mercury, or diastolic drop of greater than 10 millimeters of mercury, and/or related symptoms, a decrease in systolic BP to less than 90 millimeters of mercury. Prevalence. Orthostatic hypertension is a common disorder, particularly in older people. Studies have reported the prevalence of orthostatic hypertension as nearly 1 in 5 in older persons living in the community, almost 1 in 4 in persons living in long-term residential care facilities, as high as 60% in patients with Parkinson's disease, and frequently occurring in hospital admissions. A recent national audit identified that, where an assessment had taken place, 39% of patients, orthostatic hypertension was identified in 28% of those who went on to fall and sustain a femoral fracture. It appears, therefore, that opportunities are being missed to identify and manage this common risk factor for falls in older hospitalized patients. Causes and symptoms. Changing from a lying to standing position causes around 500 milliliters of blood to pool in the lower extremities due to gravity. In a healthy person, this is counteracted by the autonomic nervous system via the baroreceptor reflex, which increases the heart rate, cardiac contractility, and vascular tone, thereby regulating the BP to maintain adequate cerebral perfusion. Inadequate physiological response to such postural changes, especially in older people, or for example, in those subjected to periods of prolonged bed rest, can lead to an abnormally large drop in BP, resulting in symptoms that can increase the risk of falls. These symptoms normally resolve on returning to a seated or supine position. Characteristic symptoms of orthostatic hypertension include lightheadedness, visual blurring, dizziness, general weakness, fatigue, cognitive slowdown, leg buckling, coat hanger ache in the shoulders and neck, loss of consciousness. These symptoms are indicative of inadequate perfusion of the brain. While patients remain conscious, these symptoms can be described as presyncope. In this circumstance, if the patient and staff are informed and able to anticipate these symptoms, preventative measures, such as sitting or lying the patient down, can be taken to avoid falls and injury. Syncope is a transient loss of consciousness caused by inadequate perfusion of the brain. It is characterized by rapid onset, short duration, and full spontaneous recovery when cerebral perfusion is restored. Pre-syncope and syncope due to orthostatic hypertension can cause falls with injuries. However, some older people do not experience or remember symptoms immediately beforehand, meaning that orthostatic hypertension might be missed if not part of a structured assessment. Given that most hospital falls, 80–90%, are reported as unwitnessed, there is no certainty as to their cause or whether they were related to BP unless it is looked for. Decreased autonomic function associated with normal aging can cause orthostatic hypertension, but in hospitals, it is more commonly related to acute illness, dehydration, and certain types of medications in common usage among older patients. Many different drug groups can cause orthostatic hypertension, including antihypertensives, diuretics, antidepressants, antipsychotics, and those used to treat Parkinson's disease. Normally, a drop in BP on standing is regulated by a physiological response called the baroreceptor reflex. The first article in this series gives more detail on this. However, this response can be delayed in older patients or, for example, those with extensive periods of immobility who can be particularly prone to orthostatic hypertension. A transient low BP can lead to dizziness, postural instability, and even a momentary loss of consciousness, which makes these patient groups more prone to falls. However, orthostatic hypertension may be asymptomatic in some people, and often after a fall, they may be unable to recall preceding symptoms. Other causes of orthostatic hypertension are low intravascular volume, blood or plasma loss, fluid or electrolyte loss, impaired cardiac function due to structural heart disease, vasodilation due to use of street drugs or alcohol. Disorders such as dementia, multiple system atrophy, or diabetic autonomic neuropathy are also often associated with orthostatic hypertension. Managing orthostatic hypertension. To successfully manage orthostatic hypertension, nurses should discuss a management treatment strategy with the medical team and patient, rectify dehydration as necessary, which may include increasing oral intake or, if this is not possible, intravenous fluids. Request a medication review to identify potential falls risk-inducing drugs. Advise patients to avoid hurrying and remind them to use the call bell to get help to transfer mobilize. Consider supervision observation needs for patients who may not be able to remember to call for help. Advise patients when getting out of bed, particularly first thing in the morning or to go to the toilet at night, to safely sit on the edge of the bed with their legs hanging down, and if possible, feet firmly on the floor for a few moments before standing. Advise patients that before rising from a chair or, once standing still, before moving away, they should perform leg exercises such as calf pump exercises for a few moments. Advise patients to avoid situations that cause vasodilation that will lower BP, such as having very hot baths or showers, or getting overheated in a warm room. Discuss with the medical team whether other interventions, such as abdominal binders, bed head tilt, or increased salt intake, may be appropriate. Avoid prolonged periods of flat-lying bed rest and immobility. Conclusion. Falls may be avoided with increased attention to the influences of altered BP. Nurses, healthcare professionals, and care support staff should take special care when patients are assessed to be at risk of falling. It is recommended that assessment for orthostatic hypertension be incorporated into falls assessments, care plans, and educational programs for care staff. Opportunities should be created to discuss the risks and possible consequences from falling due to orthostatic hypertension and how to take preventive measures. The full version of this article with references and illustrations can be found at nursingtimes.net under the assessment skills category. Thank you for listening.